Thank you, Lourdes. Good morning to you all as well. I'm very, very thankful that you've carved out a little bit of time in your very busy schedules to join us on this webinar this morning. More importantly, I want you to know that we're very grateful for all you're doing on the front lines of the COVID-19 battle. We are all indebted to you for the care that you're providing to our neighbors and our citizens that are afflicted by this virus. Before I go any further, I'd like to introduce Cheryl Wild-Norvel. Cheryl's the Chief Nursing Officer at Broward Health Coral Springs and West Palm Beach. I think probably many of you know Cheryl. She's a fabulous nurse and a great leader with a great reputation. And we're very fortunate that she's graciously offered to help me answer questions on the presentation this morning. So thank you, Cheryl. This morning we're talking about taking care of your most important resource. Clearly that's your people. You are leading heroes on the front line. I don't use that term lightly. As an ex-military fighter pilot myself, I really do view them as our modern day heroes. And in honor of their valor, you want to give them the opportunity to operate at their peak performance. And one of the ways that we can do that is to implement 6 critical fatigue countermeasures in the midst of the crisis. So this morning we will be talking about the research, the 30 years of research that has been done connecting fatigue and patient care and patient safety. It really is a remarkable piece of research. I think most of you are familiar with it, but we just want to dig into that very, very quickly, look at a quick overview of some of that research. I will dig into 2 of the particular evidence-based papers that have come out that I find the most interesting. One of them just came out very recently in the Journal of American Medical Association talking about fatigue in treating COVID-19 patients. From there, we will segue into what we can do about that fatigue. One of those things is to implement a fatigue management policy. This is something that all high reliability organizations do. There is, however, a very important underlying guiding principle. And if you don't follow that principle, you'll really be wasting your time implementing a fatigue management policy. And I really want you to understand that underlying principle. From there, we'll talk about things that you can do very quickly. One of those is to provide fatigue countermeasures education. It won't do you any good to implement a policy around fatigue countermeasures into your policy and procedures if your team is not educated on what they can do personally. So we'll talk about what good fatigue education looks like, what should be the topics and the skill sets embedded in it, and how would you get it. From there, we'll go to managing duty times. We'll look at the science-based best practices. We won't have time to cover all of them, but I'll cover some of the more interesting ones, and I think the ones that have the most utility. Then we'll next turn to what you could do today at very low cost, and you could put into place almost immediately in terms of implementing fatigue countermeasures for your team. And lastly, we'll talk about the cost. This is not free, it's not cheap. How do you determine the return on investment and the importance of tracking your costs? Before we go any further, I want to give you a little bit about my background so you know where I'm coming from. In addition to my 20 years of work with healthcare organizations doing patient safety and quality improvement projects, I just recently completed a 42-year career as a professional pilot. 70% of my flying time, all of my duty hours, were at night on the back side of the clock. Now, you may think this is unusual, but when I tell you who I worked for, it will make perfect sense. I just retired in December as a captain from FedEx. Obviously, we fly in the middle of the night to get your packages there by 10:30. What was interesting about that journey is in 1992, FedEx asked me to spearhead implementing a fatigue countermeasures course, realizing that flying on the backside of the clock did induce fatigue and also increased the number of errors in the airline. So I worked very closely with the NASA Ames Research Laboratory, and we did implement the very first fatigue countermeasures course in a U.S. airline. What we did voluntarily back then has now become mandatory. We'll dig into that a little bit. But the point of the story is that I have implemented, designed, delivered, trained, and lived under for 32 and a half years a fatigue countermeasures policy. And I am completely and totally convinced it is part and parcel to a high reliability organization. And I just want to break off a piece of my life there and share with you what I believe are to be the best practices and how to get those implemented. Now, this whole discussion has a couple of caveats. When we began to teach this to FedEx pilots in 1992, I was amazed at the number of pilots that said to me, Steve, if flying at night on the backside of the clock is so awful and has so many ramifications for risk and is so bad for our health, why do we do it? Why don't we just fly in the daytime? I was amazed at the number of bright, educated, highly trained professional pilots that just didn't connect the dots between the business model and the need to fly at night. If you're going to deliver packages by 10:30 in the morning, the only way to get them there is to fly airplanes in the middle of the night. And so I told them, what I'm going to tell you is you have to play with the hand of cards you've been dealt. In our case at FedEx, the business model required flying at night. And the regulations at the time weren't going to help us. And as I told those pilots, you all volunteered for this, right? You knew we had to fly at night when you took this job. So given the hand of cards that we've been dealt, what can we do to ensure that we have a safe, accident-free, incident-free career with our health intact? And I'll say the same things to you. You have a 24/7, 365 patient care requirement. You can't send your caregivers home in the middle of the night and leave your patients unattended so that your caregivers can get rest, right? So that's not an option for you. You have staffing limitations. There are only so many physicians, nurses, and staff that have the education, the background, the specialty, and the training to treat COVID-19 patients, right? So you have to protect that resource, and it's hard to get more. You have cost restraints, no mission, no margin. And to top it all off, we are in the midst of the battle. We're in the middle of the crisis, and that's sort of like trying to change your engine on an airplane while it's in flight. It's just really, really hard to do. So bottom line is you're not going to be able to do everything that I talk about this morning. I realize that. But my admonition is play the hand of cards you've been dealt to the best of your ability and do something, right? Something is better than nothing. Play the hand of cards as best as you can. Now, the first thing we can do is act as leaders as if we think fatigue really matters, because it does. It's really hard to get safe, high quality, effective care in the midst of a crisis if your team is not operating at its peak performance. And if they're fatigued, they're not. And the science backs that up. We don't have time to go through all of these. I just want to talk about two of them. The first one I think is very interesting. If you have a caregiver that's been awake for 24 hours, they have the judgment and reaction time of someone with a blood alcohol content of 0.10. So basically in a lot of states, they're legally inebriated, right? So if they came to work with alcohol in their breath, you would immediately get rid of them. It's not hard to have 24 hours of wakefulness. So say you have a critical care nurse that's working on the backside of the clock, 12-hour shift, something happens, you have to ask her to stay and do some overtime. She's there for 3.5 extra hours. She's got a 45-minute commute to and from work, and she can't sleep. Her children are home. They're not at school. Her spouse is home. He's locked down as well. She cat naps during the day. She doesn't get restorative REM sleep. She shows up at 7 p.m. the next night, and you have 24 hours of wakefulness, right? And the judgment and reaction time is terribly compromised, right? Another interesting one is the next to the last one, and that is research that's just come out of China, published in the Journal of American Medical Association, showing that when caregivers treating COVID-19 patients get fatigued, it ramps up the risk of contracting the disease themselves. So once that happens, you're really on a negative cycle, and will really, really be hard to dig out of that. So there is a lot of research, a lot of evidence base that connects fatigue to a negative impact on safety and patient care. And we just have to accept the fact that it's there and make a decision that we're going to try to deal with it in some way. One of the ways that we can do that, it's more of a long-term fix though, is to implement a fatigue management policy. This is something that all high reliability organizations do, including all of your major military forces and US airlines, right? So they actually write down in writing, put it into their policy and procedures manual, what they're going to do to counteract the effects of fatigue on the workforce. This is so important in the United States that today you cannot operate an airliner in US airspace unless you have at the airline a fatigue management policy and a fatigue risk management system, right? Those two things have to be in place or the FAA is not going to certify you to operate airplanes. Now, if you're going to do that, and I highly recommend it because I don't think you can be a true high reliability organization without it, you have to understand that it takes a systems approach. That means that the organization has to do some things. The hospital itself has some responsibilities of things they need to put into place. And just as importantly, the operators within the system, your physicians, your nurses and staff, have a personal responsibility to take advantage of those things that the hospital has put into place. In other words, when they're on their protected time off, it is their responsibility to understand how to run their own fatigue countermeasures program and make that a priority in their personal life. That is why the FAA has for years insisted that pilots run a fitness for duty checklist prior to showing up for work. The acronym is I'm SAFE: illness, medication, stress, alcohol, fatigue, and eating. Have you nourished yourself correctly? So the F stands for fatigue. Are you rested? Are you really fit for duty? Have you taken advantage of the fatigue countermeasure system that's been put into place? Now, it's hard to do that if you haven't provided fatigue countermeasures education, right? Training and education and how to counter the effects of fatigue is something that all high reliability organizations do. You just can't, if you don't understand sleep hygiene and the science behind sleep and how to get the best sleep and fatigue and what the best countermeasures and how to counteract the effects of your circadian rhythm, then you're not going to be able to do your part in a fatigue management plan. So it's just imperative that you have education and training in those areas. And that training in those areas is required in most high reliability organizations. So once you've equipped your team on the science around protecting their own fatigue, the next thing you can look at is carefully managing duty times, right? So the biggest driver of fatigue in the workplace is how long have you been at work? Some recent research has come out to show that if you were to have an adverse outcome, it is 1.7 times more likely that the team will have been on duty between 10 and 12 hours, and 5.5 times more likely that they will have been on duty 13 plus hours, right? So sometimes we have to ask our staff to stay and do extra, do overtime. Just know that when you do that, you are dramatically ramping up the risk of an adverse outcome. Now, what are the science-based best practices around duty time limitations? Again, I am limited by time in going through all of these, but let me just cover a few of them that I think are very useful. The first is no more than 60 hours on duty from clock in to clock out in any 7-day period. Now, normally that's probably not a limit you're going to brush up against, but in a crisis like this, I have seen many, many reports of physicians and nurses logging 65, 70 hours of duty in a 7-day period, right? So when that happens, you're really ramping up your your risk factors. One of the more interesting one is you will not see airline crews in the U.S. work the red-eye flights more than 3 straight nights in a row, right? The FAA just won't allow that. The increase in fatigue is phenomenal, and as is the risk of incident with more than 3 straight night shift duty periods. The last one I'd like to cover is 9 hours of protected rest in any 24-hour period. So protected means you're not on call, you can't take calls from the company, and it does not include the commuting time to and from the workplace. So if you think about how this might affect you, if you have nurses working 12-hour shifts and you ask them to do overtime, and if they do 2-3 hours of overtime, they've got a 45-minute commute, that's going to affect their arrival time for their next duty period, right? So in the airline world, in other high reliability organizations like nuclear power plants, et cetera, if that sort of scenario happens, the regulations require that you have to have 9 hours of look back. So so that's going to cause you to have to come later on your next duty period to make sure you had those 9 hours of protected rest. And that's sort of a sacrosanct rule in the airlines, and I think one that really does protect the fatigue issues of the operators within the system. Something that you can do on a more immediate nature is implement fatigue countermeasures. Many of these are fairly simple and fairly low cost, and you could do them today if you wanted to. The first is based on the fact that in fatigue countermeasures, your teammates will see the effects of fatigue on your performance long before you will realize that you are affected. So you have to watch out for each other. That's why in the airline world, when a new crew comes together to start a series of trips, there will be lots of conversation about how they got the trip, what they did before the trip, are they rested, what's their level of fatigue. There's an open and honest discussion about, hey, am I tired or not, right? So that's something that you can implement on your healthcare teams. Get your frontline leaders to encourage your staff to talk to each other about their levels of fatigue. And if they are fatigued, to ask for a cross-check, right? We succeed or fail as a team. And it's a small culture change, very important culture change, doesn't cost you money to do it. The other is to make caffeine available. We all know caffeine helps counter the effects of fatigue. There's tons of science behind this. It is pretty remarkable what caffeine does in the human body in terms of countering the effects of fatigue, but it has to be used strategically. So if I were king for a day, I would make sure that somebody from the hospital was going around to every break room and making sure, especially on the night shift, that there was fresh hot coffee or sodas available. Wouldn't make people walk a long way to the cafeteria in their break time to get to their caffeine. By the same token, you have to make sure bottled water is available. The chemical reaction in your body that makes caffeine work depends on being hydrated. So if you're not drinking as much water as you are ingesting caffeine, you're not getting the full effect of the full positive effect of the caffeine. So water's got to be available, and I would make sure that somebody's making sure bottled water is there. You should be careful about the food that you offer, especially on the night shift in the cafeteria. There are some foods that are very high in an amino acid called L-tryptophan that are very drowsy inducing. They're not good for alertness. If you're not going to take them off the menu, I'd certainly identify them as being low alertness factor foods before people purchase them or ingested them. I know some hospitals in South Florida are offering hotel accommodations for their staff that are self-quarantining and are worried about infecting their families. Really hard to get rest in that sorts of situations. And I have talked to several leaders that have made that available. Probably the most effective fatigue countermeasure you can put into place is to give your folks a place to nap and encourage them to do that, right? I am a huge proponent of napping. The science behind napping is amazing. Even a 2 to 5 minute nap has been proven to be restorative in terms of reaction time, judgment, and attention span. In fact, the FAA will lengthen crew members' allowable duty hours if the airline provides a place to nap and the opportunity to nap between flights. At FedEx, they're totally invested in it. At the top, you can see the sleep room, which we have at every airport in which we have a cargo facility. Just recliners, linens are provided by FedEx. At our major hubs, we have these sort of space-age recliners. If you just want to grab a quick 2 to 5 minute nap, it has a little covering over the top to give you some privacy and noise control. And in our big major hubs like Memphis and Newark, we have sleep facilities. These are 10 by 8 rooms, a bed, a chair, and a phone, and the linens provided by FedEx. So you can see it's $1 billion company that is totally invested in the effects of napping to counter the effects of fatigue. None of this is free. It costs money, and it's easy to track how much it costs. It's way more difficult to track the benefit, the financial benefit that you get from it. But let me assure you, there is a benefit, even if it's fuzzy. So calculating the ROI can sometimes be difficult, but an ROI does exist. Carefully track your costs. It is very likely that if you adopt measures like this, that you can be reimbursed for them under the government stimulus money. So it is important to track your costs if you do it. Remember, play the hand of cards that you've been dealt, do what you can do, and doing something is better than nothing. And whatever you do, I wish you the very best. So let's take some questions from participants. I think some questions have already come in, and I'll turn the first one over to Cheryl to answer. The question is, Steve mentioned that Memorial is making hotel rooms available for caregivers in some circumstances. Have you done anything like that at Broward? And if so, what steps to ensure alertness have you taken?
Hi, Steve. Thanks for the question. Thanks for that great presentation. It's, you know, to me, it's so striking. I've been a nurse for over 32 years, and it's striking how similar and how different we are hospital and healthcare between the hospitals and the airlines. So thanks for that. So in regard to making hotel rooms available, Broward Health, to begin with, we talked about this at the very outset of the crisis when we first started seeing, you know, some of our patients arrive. What we found really when we took it to the staff was that overall there was kind of a low demand for this in the beginning. We did make arrangements, and we connected with local hotel chains, and we're in discussion in regard to offering discount rooms for the staff, which of course would be at the hospital expense. What we found, and some of the feedback that we did get, was that the staff are so isolated to begin with, you know, with our social distancing, people who are non-essential being at home, not being able to see friends and family. One of the things that they really do love is to go home to their families, obviously, but with that being said, especially on the outset of this crisis, there was this fear, this overarching fear of bringing a COVID-related illness back to the families. So while staff were afraid to go home, when this sentiment really started to crescendo in Broward, we, as a system, I think we just got better at PPE. We sent more education out, we made more available, we increased our PARD levels, and had a lot of conversation, a lot of education around what the CDC guidelines were, how do you protect yourself. We did constant rounding and put some education teams out so that we could be in touch with our staff and really hear their concerns. And once we were able to mitigate that, make sure that they had the personal protective gear that they needed, we saw really that fear level begin to decrease. So while we do offer the hotel rooms for people who may have been exposed, who are self-quarantined and need to quarantine away from their families, we really haven't seen that big of a demand for it. I can say that one of the main differences for us as well is in the beginning of this crisis, and I'm sure most of the callers can relate to this, but in the beginning there was a long time between when you tested a patient who came in and when you got that result. So we had what we would call PUIs, or person under investigation, because we didn't know if they were positive or negative. So it took a while for us to get the testing back from the Department of Health and from the Quest labs. We've since gotten much better at it. We have point of care testing now that can give us more immediate results, and that, I think that has impacted us as well. So when there is question, we can get an immediate test result back, and it really it helps to alleviate the fears among healthcare workers as well.
Great, thank you.
One of the things.
Go ahead, Cheryl.
Sure. One of the things I was going to say was that when we talk about fatigue, what we see in the hospitals is obviously it's not just physical, but there's this emotional fatigue. There's this thing that is very common among healthcare workers, what we call burnout. And while it may not always be, be under our control to control a lot of the physical fatigue, we can help to manage the emotional and the burnout with our staff. And I think that's important.
Yeah, that's a great point, Cheryl. Can you take another question?
Sure.
The second one that's come in is, are you using travelers or agency nurses to supplement staffing to be able to control duty time?
Yes, absolutely we are. I think all of the health systems that I've been in contact with down here, especially in South Florida, that was one of the things that we did originally, looking at, what is this crisis going to look like for the hospital systems? How is it going to impact us? And how do we effectively manage our communities, our patient population? How do we make sure that we have enough resources for them? And then to really tag straight along with that is, how do we support our own staff here and make sure that they have the resources that they need to care for these patients? So yes, we did originally reach straight out to the nursing agencies, and respiratory therapy has been another big support for us. And we brought in staff to care for not just the ICU and the ER, but also the med surg, the folks on the front line who are dealing with, getting in and out of PPE every day. And what's really important about the agency support is that we're able to add this to our core staff and then decrease the ratios, the nurse-to-patient ratios. So it really helps to give the nursing staff time to don and doff their PPE, go into the rooms, protect themselves and protect the patients without having that additional factor of, a burnout, very high ratio, which we really believe has been part of what makes it easier for our nursing staff, if you will. One of the things that we can do for them.
Great. Thank you, Cheryl.
Steve, I saw a quick note from Maria talking about Asian culture and napping, and that it may not always be considered something that is positive. One of the things that I saw as we were going through this, Maria, so thanks for that comment, was we historically in hospitals, especially as administrators or as managers, never really encouraged napping, and that was something that was striking to me. I thought that some of my staff would probably chuckle at me if I said, "Hey, take a nap," and they'd be like, "Really?" So I think that we have an opportunity to really look at our culture and how we have driven our staff and give them allow them to take a break. Allow them to close their eyes for 15 minutes or 20 minutes if they're on their break, and really kind of loosen up what our thinking is around that.
Yes, I think that's probably one of the most valuable cultural changes that healthcare could make. We actually used to teach this at LifeWings in the beginning of our CRM and Team Steps courses, but we got so much pushback on it that we eventually drifted away from it. I can tell you from my own experience as a professional pilot that I used to bid trips at FedEx based on which air cargo facility had the best napping room, because flying in the backside of the clock, the nap made all the difference, right? If I could get, typically I would have more time than a nurse would for a nap, just because of the time it takes to unload and reload an airplane. But if I could get a 30 to 45 minute nap, it made all the difference on my alertness on the return flights. So it became a huge driver in how I functioned as a pilot. Once you see the effects of napping, you'll never want to go back to not napping on long periods.
Steve, Cheryl, we have another question in the chat. What type of shift hours are you running now?
In the hospitals, generally in South Florida and in the health system that I'm working in now, we do 12-hour shifts. But we do offer, because of what's really going on with this crisis and how we have different needs now in the hospitals, we're offering up not just bonuses for people who might come in and do an extra shift, but really more flexible hours for those folks who come in as helpers. One of the things that we did, especially I want to say in the ICUs, where we have seen patients who are a lot more critical, and they're a lot more critical for a lot longer time. Their length of stay is up, maybe on ventilators for a week or 2 weeks, sometimes 3 weeks, is we've been able to reallocate staff from areas where we have cut back from. So our surgical volumes are low because we have cut back on all elective surgeries, right? And so we've cut back on elective procedures, and some of the staff from those areas are able to actually go into the ICU and may not be able to take a patient assignment, but would be able to do different things like be a runner, or help to turn patients, or be available to answer the phones, or keep a good eye on the call lights or the phone calls back and forth from the families, because remember, we don't have family members in now. So with those helpers, with those types of positions, we are able to offer them whatever hours they can do for us. If they can come in on a 4-hour shift or a 6-hour shift or an 8-hour shift, we're welcoming that additional help, and I think that they're appreciating that. But for the most part, they're 12-hour shifts that we're seeing.
Great. We do have some more questions coming in, so if you still have time, we'll get through these here very quickly. There's two here that are similar. One is, have you found a drop in productivity? And the other one is around the effect on your teams when they're dressed in full gear of PPE and shields while they're working the 10 and 12-hour shifts. How has this affected fatigue and burnout at your facility?
Yeah, absolutely. So the first question I can answer very quickly. We have absolutely seen a drop in productivity. We predicted that. We allow for that, especially on what we designate as our COVID units. It's not business as usual. We can't take care of these patients on a 1-to-6 ratio if we're in a med-surg area. We've gone from 1-to-6 to 1-to-3. And 1-to-4 if they're a little bit more stable. But what we've seen, and I'm sure all of you have seen out there, is patients, when they start to what we call kind of quote unquote go bad, they do it quickly. So we need a lot of resources around. So productivity, absolutely, that's something that we just have to manage as a system. But first and foremost, our concern is the patient safety and the staff safety. So productivity, right now, all the rules are kind of broken. As Steve, as you were flipping through the slides, and one of the first slides, picture of the nurse who looked like she was kind of bruised and fatigued, I thought that is real. I mean, that's what we're seeing. We're seeing folks who have been had N95 masks on and masks over that and shields over that, and there are a lot of different effects on an individual when that happens, not just the physical effect, the bruising, which we've seen, and the breakdown of skin. Nurses are masters of innovation, and I've seen, and respiratory therapists, clinical people, healthcare providers. So I've seen things like Mepilex and Duoderm on cheeks to prevent breakdown. I'm not advocating for that. I'm just saying that we've been able to create differences in our approach to how we care for patients and how we protect ourselves. But I also think that the physical barriers between us and our patients really affects nursing and clinical care providers, physicians. It affects us. We're that much more removed from our patients. We depersonalize a lot, and I do believe that the effects on the staff are direct. We're not used to being those kind of providers of care. We're not used to being behind a shield. We're used to being up close and personal and doing what we need to do to care for our patients. So that emotional burnout or that emotional impact, I think, does definitely affect the well-being of the nurse, and that's something that we really have to focus in on and make sure that we're protecting.
Cheryl, here we are. How are you managing the nurse morale?
Good question. I think that, like I said earlier, there's not much we can do as a healthcare provider to help to protect the physical, but we can address the emotional and the fatigue that comes with emotional burnout. Some of the things that we are doing really is to focus on not just all of the negative, because we see so much negative. We work in it, it's hard, it's scary. We go home, we see it on the news, we hear it on the radio. We've got to be able to intentionally provide an outlet for that. And we've got to intentionally look for the positives and the wins. And so some of the things that we do are COVID patients who have been shut away and isolated. We have iPads for them, and the staff really take joy in doing little birthday celebrations in full PPE in their rooms. We have a thing at Broward we call Code Happy, which is an overhead announcement inviting all staff to go to a certain exit where a patient is being wheeled out, a COVID patient who has recovered and now on their way home. And we line the hallways, you see this all over the news, and we clap for them, and we cheer for them, and we see tears, and we see joy, and that builds us up as caregivers. I think it's important for administration to bridge the gap between the caregiver at what we call the point of care, right at the bedside, and the administrators who are helping to try to provide them all the tools they need to do their jobs. But we daily get on an overhead announcement and talk to them about how proud we are. We thank them for all the work that we're doing, the staff. We talk directly to the patients and say, you are in the best of hands, and your caregivers are dedicated, and we thank them, and we're praying for you. I think that developing a sense of family and togetherness is a key to helping kind of manage that emotional stress.
Yeah, those are all fabulous techniques, Cheryl, and you're to be commended for doing them. One thing I might recommend that I've seen used very successfully, and you mentioned this yourself, the negative always screams, the positive only whispers, right? So you have to find those whispers of the positives and then amplify them. One technique you could do in meetings or huddles is 3 good things, right? So they don't have to be the best things that have ever happened, but just looking back over the shift or the previous day, what were 3 good things that happened during the shift? How did it make you feel? And what was your part in making that happen, right? So it forces you in a structured way to think about the positive that's happened to you.
Yeah, I like that.
All right, Cheryl, Steve, we're going to squeeze in one last question here, and that's coming from Jason Jacobs, and he's asking, Cheryl, with the volumes and census down, were you able to repurpose clinicians to augment staff managing the COVID-19 patients?
Yes, absolutely. And that has been a big key to our success, because when the volumes are down and folks get flexed off who are already in a financial crisis, that kind of, impacts them in one way. But the staff who are left behind really need the extra support. We've been able to reappropriate staff from our same-day services area, which volumes have been very low, our GI suites, our recovery room nurses have been fantastic in our ICU. We have folks from our operating room suites who may have come from like med-surg areas who have volunteered to go back to the med-surg areas and help support those areas. And we also have kind of almost non-clinical people or nurses or healthcare providers who are in areas that are not direct inpatient care, who, because the volumes are down, we may not need their services as much. So we've been able to reallocate those folks even to the emergency departments, and they have been able to help triage or at the doors, because we do screening and temperature screenings at the doors. We've really had to think out of the box, and I've just seen an incredible rally of the teams here, and really a reaffirmation of the fact that we're all in this together. We are all, here for one purpose. Our one purpose is to care for our community, to make sure that we can provide the safest and the most effective outcomes. And at the end of the day, to be proud, like Steve says, that I at least did a couple of things that impacted somebody's life in a positive way, and that I feel good about leaving the job for the day and then coming back the next day.
Fantastic. So, well, thank you so much, Cheryl. We here at the South Florida Hospital and Healthcare Association definitely thank you and your staff for everything that you do today and every day of being providers. We'd like to thank our members, LifeWings, for providing the content of this webinar that we've run in the month of April. Steve, I'll hand it over to you if you want to have any closing remarks, and we'd like to thank everyone for your time this morning.
I would just like to say, Lourdes, that to remind everyone that you are leading heroes, right? And they deserve the very best in terms of fatigue countermeasures. We will prevail. I think Cheryl's message was very uplifting. I want you to know all of us that are not clinicians are very grateful. Thank you all.